Slides up? Oh.
No, you can begin. No, we don't have any slides. You can.
Okay. Okay. Good morning, everyone. I'm Gus Gazzard from Moorfields, and thank you very much indeed for the invitation to speak. I'm going to kick off with some of the bad stuff this morning. We're going to hear later about how wonderful cataract surgery can be, even in glaucoma patients, and some of the wonders of femtosecond refractive IOLs and all sorts of developments in the world of cataract surgery that may have passed some of our glaucoma minds by. I'm going to start off with some of the complications that we can get, not generally from cataract surgery, we know that there are a lot of those, but very specifically from the intraocular lenses themselves. I think just intended as a reminder of what intraocular lenses can cause, what cataract surgery can cause, and perhaps to temper our enthusiasms for what's coming later. And ever since the days of couching, for the last 1,000 years, we know that cataract surgeons have caused glaucoma, and even in the sort of more modern surgical era, the pre-modern surgical era, right the way through to intracapsular cataract extractions and zonulysis with enzymes causing specific types of glaucoma. There have been a multitude of ways that cataract surgeons can damage the angle, but it was only really until Harry Ridley came along and started putting bits of plastic into eyes that intraocular lenses themselves became a specific and definable cause of pathology and raised intraocular pressure. And as those lenses became more inventive, as the mechanisms for fixing those lenses in place, particularly in the anterior chamber, became more ingenious, we started to see, as I'm sure you'll be aware, a number of lens-specific complications that led to chronic inflammatory processes, chronic release of pigment, inflammatory cells, and the steroid treatment necessary for that themselves started to cause problems. And with uveitis glaucoma hyphema syndrome described in 1979, particularly with the choice ACIOL, but then a variety of others, there was a clear instances of sort of episodic injury to the iris, but also a chronic low-grade grumbling inflammation. And whether that was the iris, the ciliary body, or angle vessels themselves bleeding, it was the presence of blood, the dispersal of pigment, and then the inevitable steroid pressure response for the treatments that were required to deal with that started to become recognized as a specific IOL-related problem. And this was characterized with hyphema, sometimes episodic hyphema, pigment dispersal within the anterior chamber, and that chronic inflammation, and often a fluctuating of symptoms. And these were clearly quite severe instances of problems caused by the intraocular lenses. There is still a hangover and a persistence of milder forms of this disease that to this day often go unrecognized. And to try and introduce the most simplistic or simple of classifications to try and guide our thoughts around an IOL-induced glaucoma and a schema for that. Clearly, these are secondary glaucomas by definition, and the simple schemes that we use for other things of open angle or closed angle are useful here because they, as they do for primary glaucomas, will guide our thoughts and therefore guide our treatments and interventions along the appropriate pathways. So clearly the open angle glaucomas can be inflammatory, pigmentary, steroid-related, all in a group. They're often occurring together, though not always. And the closed angle glaucomas will occur either with direct angle and trabecular meshwork, peripheral anterior synechiae formation and direct damage and trauma, or with iris bombae specifically and pupil block. And clearly multiple mechanisms within this group are very common. The differential for a full-blown severe uveitis glaucoma hyphema syndrome in all its glory has to be those other forms of long-term chronic inflammation and idiopathic uveitis. The possibility of retained lens material, though I'm sure nobody thinks they ever leave anything behind, but there is always that possibility. A chronic endophthalmitis, which frequently go under-recognized and has to be in the list of things that we're considering before we start blaming the lens itself, and then some more specific things such as local neovascularization of the angle for whatever reason. And all of this takes very careful gonioscopy, a subject close to my heart, and an assessment of iris transillumination patterns as a guide and a pointer towards the fact that this may be a secondary traumatic mechanism of pigment dispersal and pigment release into the anterior chamber, rather than something that's a primary mechanism, such as from pigment dispersion syndrome. And OCT, and particularly UBM, ultrasound biomicroscopy, are particularly useful in this circumstance. UBM, because it can image, albeit with less resolution, it can image through the iris, and it can tell you where haptics may be that you can't otherwise directly observe. And you may be able to identify a haptic-related or IOL-related problem before you start to get full-blown transillumination defects, identifying the specific point of contact between those two structures. And clearly we're going to lower the intraocular pressure, treat the inflammation, which may or may not respond to anti-inflammatories, or you may end up in a chronic cycle of long-term steroid use where you cannot wean them off the steroids. But if they've got true pigment dispersal and there is a confirmed long-term chronicity of problem, you've got a long-term chronic uveitic problem, then it may well be that you have to deal with the root cause, the underlying problem that is generating that chronic inflammation and pigment dispersion. Clearly, a lot of this is due to trabecular meshwork, angle damage and trauma. There are multiple insults that the act of cataract surgery and its subsequent steroid use, particularly in the setting of chronic inflammatory responses, can cause. We certainly have a number of patients, particularly in London, African-derived populations, Afro-Caribbeans, who simply get a long-term chronic grumbling inflammation that even with good surgery treated appropriately end up with a chronic anterior uveitis after the act of cataract surgery, who never get off steroids, and some of those patients go on to develop significant pressure-related problems as a result. So we clearly are going to, there's a potential risk of residual proteins, prolonged inflammation, particularly in some circumstances in some at-risk groups, as well as the steroid response, and then direct traumas from the direct trauma to the tissues from the intraocular lens, whether that's from the optic itself or from the haptic, leading to pigment dispersal. And clearly those with a predisposition, a prior compromise to the trabecular meshwork are likely to be more prone to a further insult to that trabecular meshwork. So obviously, if you've got a pre-existing outflow facility restriction, you've got pre-existing problems with your trabecular meshwork and outflow pathway, then you're more likely to have a pressure response afterwards. And pseudoexfoliation is probably the example par excellence for that. It's very difficult to know what the true prevalence for this is, because a lot of these problems are hidden, a lot of these problems are sat on for a long time, a lot of these problems occur later. The true glaucoma as a result may crop up months or years later, and true prevalence estimates are therefore hard to come by. But it certainly seems to be that for a lot of these patients with specific intraocular lens-related problems, that the primary insult is the intraocular lens uvea contact and subsequent trauma, pigment dispersal, and then the secondary effects on the trabecular meshwork, particularly if it's has a predisposition to problems. But clearly, it's not only anterior chamber lenses of the last century that are causing this. Posterior chamber intraocular lenses themselves can also sublux, dislocate, shift, move, even when they were put into the right position in the first place. And that's going to be particularly a concern for those individuals who have initially weak zonules, or zonules that are traumatized in perhaps brutal or aggressive surgery in the first instance. And these themselves can clearly lead to inappropriate and pathological contact between the piece of plastic that we put into the eye and that very sensitive structure that likes to release its pigment wherever possible, the iris. So we end up with dense pigmentary bands in the angle, pigment dispersal and obstruction to outflow, and raised intraocular pressure as a result of lens subluxation, aside from all the problems that a lens dislocation can give you to visual acuity, probably clearly from the refractive problems it generates. So some people have tried to look at the effect specific of cataract surgery in these pseudoexfoliation patients, and while there's some evidence from some small surveys that there may be a possible long-term protective effect, we also know that there's a very high rate of long-term zonular weakness in these at-risk patients. So particularly in the pseudoexfoliation patients known to have weak zonules, there's a significant incidence, even with relatively short 2 to 3 year follow-up, of long-term zonular weakness leading to lens capsular bag, intraocular lens capsular bag complex subluxation, and as a result, long-term trauma, and we are all living longer. So with life expectancy now over 80 years in the UK and continuing to go upwards, it is likely that our longer-lived patients may well outlive their zonules. And the intraocular lenses that we are now putting into 60-year-olds for refractive reasons, or at least some of us, may well come back to bite us when those zonules are weaker or weakened, and through natural aging processes, in a third of a century time, those patients come back at the age of 90. So I think we need to temper some of our enthusiasms with the reminder that many of our 95-year-old patients in our clinic, of which there are a number, but certainly our 90-year-old and our 85-year-old patients in our clinic, they never expected to get that old, and nor did the people that were operating on them 20 years ago. And our patients of 65 today have a very long life expectancy. Remember, our life expectancy goes up as you start to get into your 60s and 70s decade, because we know that those people actually have a significant longevity ahead of them. Now, inappropriate placement of lenses in either the wrong place or the wrong lens in the right place can also cause problems. So if you put the wrong lens in the sulcus because of capsular compromise, particularly single-piece acrylic intraocular lenses with thick, square-edged haptics that are not designed to be in the sulcus, that have a greater volume, a sharper edge, and a propensity to cause posterior iris surface chafing and trauma, there is a clear incidence with those of pigment dispersal and long-term uveitic pigment-related pressure problems. These tend to have very localized, atypical as in they're not pigment dispersal, pigment dispersion syndrome type patterns of transillumination defects. And careful transillumination prior to dilating may be the first sign that that is the underlying cause of the problem. And it's not a pre-existing PDS that was missed. It's not an unrelated problem or naturally heavy pigmentation in the angle, that this is a change in angle pigment because of a specific IOL-related problem. And these patterns, as shown here just from a couple of case reports in the literature, can be quite obvious or really quite subtle, and you have to look for them carefully to track them down. And in some of these patients, it's UBM, as I mentioned before, that can really help you with the diagnosis, because it will be able to identify the position of the haptics and show you that the haptic may not be where you thought you placed it, or may not be where their original surgeon thought that they placed it. And if there is a haptic in the sulcus, you can get direct haptic iris contact with direct trauma, as in this case, or this same paper, but a different case, same series of IOL-related pigmentary glaucomas diagnosed with UBM. You can get an optic tilt, shown here where one edge of the optic is in contact with the pupil margin and the iris because of an inappropriately placed haptic. And misplaced or displaced haptics because of large rexes can be a direct cause of intraocular related pressure. Clearly, treating the underlying cause may well require repositioning that lens, but if it's been there for several years, that may not be you may not be able to do that safely, and it may be that simply amputating that haptic and removing a single haptic may be what's required, and may have a less traumatic but equally successful way of resolving the contact between iris and IOL. Now, clearly there are other lenses that I, as a glaucoma specialist, know nothing about and occasionally see when they come with problems, and phakic IOLs are beyond my personal surgical experience, but are clearly, occasionally, in some instances, a cause of chronic uveitis and pigment dispersal. So we are inventing just as we realize that some problems we can avoid with correct sulcus, choice of sulcus lenses, we are constantly inventing new problems and new mechanisms for causing chronic iris trauma. And clearly the treatment for these is similar. It's mild, very mild inflammation, may be short-lived and dealable with simply anti-inflammatories, but we may need to deal with the root cause with intraocular lens positioning or revision. Angle closure can also be due to a number of pupil block mechanisms. You can have a number of angle closure mechanisms. You can have direct peripheral anterior synechiae formation in the presence of chronic uveitis, so non-pupil block, or you may have pupil block mechanisms of secondary angle closure due to the intraocular lens. And anything that encourages the formation of synechiae, posterior synechiae, or puts the anterior surface of the intraocular lens more anteriorly, so it's more likely to come into contact with the pupil margin, is likely to cause that. So any anterior lens shift, such as late capsular block syndrome, or an incorrectly orientated IOL that's upside down and now has anteriorly instead of posteriorly angulated haptics, can cause that. And clearly chronic uveitis can give you the sort of 360-degree posterior synechiae with occlusio pupillae that may well need surgical intervention. These are, generally speaking, not difficult diagnostic problems, but they're something that you need to think clearly about the underlying cause as to how you're going to deal with that, and surgical PIs in the presence of that sort of inflammation rather than simply a laser PI. And then you can get pupil block due to synechiae to the anterior capsule and other forms of cataract surgery, chronic inflammatory related problem. You can also get posterior chamber lenses subluxing into the anterior chamber. If your rexus is too large, your orientation of your lens is incorrect. There are multiple case reports in the literature. And of course, the old favorite in the heat of the moment, the anterior chamber intraocular lens that you never intended to put in the first place because you really did want, you meant to preserve that capsule, but on that occasion you managed not to. Very easy to forget to put in a laser iridotomy or surgical iridotomy at the time. Later laser iridotomy may or may not be sufficient for that, but it's certainly a cause, even now, of intraocular lens-related raised pressure. And newer forms of anterior chamber lens are still prone to the same problem. And we still get a steady trickle of patients coming into casualty with very high pressures because patients who clearly needed a PI didn't get it. So intraocular lens-induced glaucomas persist in the modern era. Inflammatory, pigmentary, and pupil block mechanisms are predominantly the causes of those, but we need to isolate and think clearly about which they are so we can treat them appropriately. We often need to go right back and remove the underlying root cause and not merely treat the pressure, because therein you will end up with an undertreated chronic problem that causes more problems. And often careful surgical technique that we're about to hear about for the rest of this session, and some of the advances looking at specific ways of improving our cataract surgery, perhaps even femto for some of us, may well reduce the incidence of problems and reduce the incidence of secondary intraocular related pressure rises. Thank you very much.